Welcome, everybody. Today we have with us Dr. Daniel Hollander, a professor of medicine at the University of California, Los Angeles, School of Medicine. And he specializes in the therapy of inflammatory bowel disorders. Welcome today, Dr. Hollander.
Thank you.
It's great to have you on the call, and I'm really looking forward to today's discussion about IBD. And the first question that I have for you today is, what is IBD versus IBS?
That's a very good question. And IBD stands for inflammatory bowel diseases. And what it means is that there is an inflammation in either the small intestine or the large intestine or both. In contradistinction, IBS is a disorder that's very common where people have abdominal discomfort but don't have inflammation. So it's IBS stands for irritable bowel syndrome, and it's a syndrome that is totally separate from IBD. It's not the same thing at all, and mainly has no inflammation associated with it, just discomfort.
So easy to confuse the two because the initials are similar, but the disorder is quite different. IBS, no inflammation or measurable inflammation, and IBD always comes with inflammation.
That's right.
Yeah. Okay. So can you tell us a little bit about the etiology of IBD?
Right. The bottom line is that we don't truly know what causes IBD, but there are certain clues that are very important. First of all, IBD is very common or more common in developed areas of the globe, the United States, North America, Western Europe. At the same time, IBD is fairly uncommon in developing countries. Just to give you an example, in the US or in Canada, about 0.5% of the population has inflammatory bowel disease, which is really a very large number. What's interesting is that if we study immigrants from developing countries such as China or anywhere from Africa or wherever, as they move to the developed countries such as Western Europe or the US or Canada, their incidence of IBD markedly increases. So that's one clue that we're dealing with something that is inciting or instigating the disease in the developing countries, which is obviously in the environment in some way. The other thing that's really interesting is that 30 to 50 years ago, IBD in the developed countries was a very rare disease, whereas now it's becoming more and more common. And so there is something that's changing in our environment that is causing inflammatory bowel disease. Now, that something could be something in our food, it could be something in our water, it could be something in the air, or something that we come in contact with. We really don't know. And there have been a lot of studies along these lines. One possible factor is hereditary factor or genetics. We know that if we study identical twins, meaning that they have same DNA when they're born, that the concordance, that is the percentage of one twin having the disease and the other one having the disease, is about 50% or somewhere between 20 and 50%, depending on which study you look at. So clearly there's a strong genetic component. And the other clue that we have is that families that have an IBD patient have a higher likelihood of having another relative. It could be a close relative or a distant relative with IBD. So it seems to have a genetic component as well as environmental component. We know of some genes that predispose people to IBD. One of them is called NOD2, NOD2, and it's a gene that has to do with bacterial recognition. And so another thought that has kind of come into the field is that perhaps there's some bacteria in the environment or in our intestine that also help instigate the disease. But again, no specific bacterium has been found, and we're not any closer than what I just said, basically, in understanding what causes the disease. The one thing that patients always ask me is it psychological? Is it tension? Is it stress or whatever? And I have to tell them that basically the evidence is very clear that stress can exacerbate any disease. So if you're prone to have asthma, if you're stressed, you'll have more asthma attacks or migraine or any other disorder. So there's nothing specific about stress and IBD. It certainly can exacerbate the disease, but it's not a unique factor in the disease itself. So that's kind of where we are. Another one that's really interesting is there are two inflammatory bowel diseases. One is called ulcerative colitis. It's a disease of inflammation of the superficial lining of the intestine. The other one is called Crohn's disease, and it has a deeper penetration and inflammation, and it involves both the large intestine and the small intestine. And Crohn's disease originally was described, at least, by Dr. Crohn in Mount Sinai Hospital in New York. And this is predominantly a very Jewish hospital. So the idea was, to begin with, that maybe this is a more common disease in Jews. But in fact, the evidence is that the incidence of IBD is the same in Israel or in Australia or Scotland or the US or anywhere else. So those are two, that's kind of an important issue, because some people ask me, why do I have Crohn's disease and I'm not Jewish? Well, because it has no connection with the two.
Yeah.
That's kind of the background that I want to give you.
Well, that's interesting. That brings up several questions from an Ayurveda point of view. Joyful Belly, we do Ayurveda, and one of the things that you've mentioned is immigration, and Jews outside of Israel, they have a history of immigration, and so that brings me to wonder: have there been any studies on mobility or immigration, or not a particular change in diet, but just the fact that someone is changing their diet, or they're exposed to different bacteria than the location that they were born in, if that has anything to do with incidence?
Yes, I think that's a very good question. And yes, there have been studies of people migrating from India to Great Britain, for example, and they develop the same rate of the disease once they are in Great Britain, and especially their kids do. And there have been some good studies of Chinese migrating from mainland China to Australia, and again, showing the same thing, that the first generation born in Australia have the increased incidence of the disease as compared to Chinese in China. So yes, obviously, and when people do migrate, there's no question that the diet changes, the environment changes, and all kinds of other factors change. And it's really very difficult to pinpoint specifics in the environment or in the diet. But definitely migration from a low area of incidence to a high incidence area does change the rate of the disease.
Fascinating. So how is diagnosis of IBD made? You mentioned that Crohn's penetrates deeper into the tissue, ulcerative colitis a little bit more superficially, but could you talk more about how the diagnosis is made?
Right. Mainly our suspicion for the diagnosis is high, especially if someone develops abdominal discomfort, diarrhea, and especially bleeding with the bowel movements. Then we are looking for either cancer or inflammatory bowel disease as the two most likely explanations, and sometimes hemorrhoids. And so what we do when we suspect inflammatory bowel disease is do a procedure called colonoscopy, which is an insertion of a flexible instrument through the rectum into the large intestine. And we visualize the lining of the intestine and biopsy it. And when we visualize it in Crohn's disease, we find, first of all, sometimes disease in the end portion of the small intestine, which we can reach with the colonoscope. That's number one. And in ulcerative colitis, we don't see any inflammation or changes in the end portion of the small intestine. The other one is that in ulcerative colitis, there is a more uniform change in the inflammation of the bowel, whereas in Crohn's disease, we see skip areas, we call them. There's normal mucosa and then abnormal lining. And thirdly, we do biopsies, and we can look to see the depth of involvement. And although biopsies sometimes cannot tell the difference, sometimes we do see very deep inflammatory changes in the biopsies in Crohn's disease, and we even sometimes see granulomas in the mucosa. So the endoscopy, the colonoscopy, and the biopsies all are very important. And secondly, if we see involvement of the small intestine as well as the large, then we know it's Crohn's disease. So those are the main diagnostic findings that we use.
Now, how is IBD differentiated from just any other inflammatory cause, such as from a bacterial infection? How is that determined?
That's a very good question. Usually, bacterial infection, such as Salmonella or E. coli or other bacteria, can cause inflammation and can even cause diarrhea and bleeding. The thing about it is that it's very transient, number one. And number two, we routinely culture the stool of patients who come in first and look for bacteria, we look for parasites, we look for any infectious organisms. We even look for evidence of virus diseases because there are some viral diseases that can imitate IBD. And so we look very carefully at the biopsies and culture the bowel movement to see if we can find evidence for that.
Okay, great, fascinating. So, and then if you confirm the diagnosis, then what? How is this treated, or how do, where do we begin?
Right. One of the first questions patients ask me is, should I be on a diet? And it's a very obvious question. And indeed, in the past 30 to 40 years ago, there were no specific drugs for IBD, and so a lot of physicians used low residue diet or all kinds of dietary modifications simply because there were no medications that were effective. But the evidence is that if we test patients, large number of patients, on specific diets versus no diets, there are no differences whatsoever. So that no one has been able to show in any controlled way that diets really help patients with inflammatory bowel disease. So what I usually tell my IBD patients is, if you know that something bothers you, don't eat it. But it's very personalized, and I can't really predict a specific diet that will help your disease. So that's number one. Number two, there are medications, and the original medication that was used was hydrocortisone or cortisone-like drugs. The drug we use primarily is called prednisone, which is a cortisone-like drug. And originally that was the only drug that was used at the time, 30, 40 years ago. And it is very effective, but unfortunately one gets enormous amount of side effects. It causes bone leaching of calcium, it causes fractures, it causes weight gain, causes muscle atrophy, it depresses immunity in general. So we use prednisone or cortisone-like drugs very sparingly and for very short time only. The second group of drugs that was kind of developed was what we call 5-amino-salicylic acid or 5-ASA drugs. The original one was called azolfadine, and they are very weakly effective, but not very strongly effective. And the next group of drugs that was developed was what we call immunosuppressives. These are drugs like 6-mercaptopurine, or 6-MP for short, that are drugs that suppress the immune response and suppress inflammation. And approximately half of the patients will respond to 6-MP, one to some extent or another. The problem with these immunosuppressive drugs is that, as the name implies, they suppress the immune response generally, so they make patients more susceptible to have infections, and we have to follow the patients very carefully. And also these drugs suppress the bone marrow, and we have to very carefully follow the patients and adjust the dose accordingly. So these were kind of the basic drugs we've had up until the last 10 or 15 years. Then were added what we call biologics. These are antibodies to specific pro-inflammatory compounds that the body makes. One of them is called TNF-alpha, which is a big mouthful, but basically it's a hormone-like agent, or cytokine we call them, that is pro-inflammatory. And there are some antibodies that we can use to inject into the patient in order to neutralize this pro-inflammatory compounds. Humira is a trade name of one of these. These are antibodies to TNF-alpha. And I may be getting too technical, but basically this is a very commonly used medication now to either supplement the 6-MP or in order to replace it completely. The side effects of these drugs are a little less than the 6-MP, but still predispose patients to infection. And then the latest one is called Entyvio, and it's an antibody not to this one pro-inflammatory factor, but it's an antibody that is working against a compound, again, it's a mouthful, and I apologize, called alpha-4 beta-7, but it's an integrin. It's a molecule that allows the inflamed cells, the white blood cells that are pro-inflammatory. This antibody blocks their ability to migrate into the intestine. So it works by a different principle. And that is the latest one that we use clinically. And again, it's very effective. But given all of these possibilities, plus many other drugs that are being developed, I think we're seeing most of our patients do much, much better today than they were 10 or 15 years ago. Many of them can return to very normal life, work, function, travel, do whatever they want, and lead a very normal life, although they depend on these medications to suppress their disease.
Now, what if they move back from where they came from? Does it go away then, or does it stay? Has anyone ever checked that out?
Yeah, that's an excellent question. And no, I don't know of any good study to show whether leaving the area of high incidence towards, let's say, going back to India or China or someplace in Africa. I don't know of any good study along these lines, but that would be a very interesting observation.
So from what I'm hearing is that there's just been a lot of creativity in this area in terms of pharmaceuticals being able to block this inflammation at various different levels, whether it's suppressing the immune system generally, all the way down to this last drug that prevents the white blood cells from migrating into the the intestine.
Into the intestine, yes.
Yeah.
Right.
Well, that's fascinating.
Yes, there is a lot of interest in it because it's one disease that's clearly immune related, but a disease that we can see very easily through a colonoscope, and we can biopsy the intestine and measure our effect. So that's the reason that pharmaceutical industry is very interested in it. And secondly, because it is very common in the West.
Yeah, and so the theory with that is that if they can test it out and get things working in the intestines, then it may be useful for other conditions that are non-intestinal related that are harder to test. Is that Is that what you're saying? That's why they're
That's
interested?
exactly right. And
Yeah.
indeed, the same drugs are used very commonly in arthritis and rheumatoid arthritis, or in some skin diseases or other immune-related disorders. Yes.
Hmm. Great. And you answered a little bit about the role of diets in IBD therapy or prevention. And in particular, you said that there was no real sort of one-size-fits-all diet for all patients,
Right.
but that if a person knows that something bothers them,
Right.
that they should stop eating that food. Now, what are some of the signs and symptoms that a food is not working for them, or is that it's a food that they probably should cut out? And how do they even go about that process of identifying which foods are aggravating them?
Right. It's very difficult because my patients tell me very clearly that one day they may have more abdominal discomfort because they ate broccoli, let's say.
Hmm.
But then some other day they might eat broccoli and have no problems whatsoever.
Hmm.
So patients have a hard time identifying a consistent dietary component that is bothering them.
Hmm.
But some patients are very good, and some of them tell me that clearly whenever they eat whatever it is, they get discomfort. So I just say, well, don't eat it. That's just fine. And the only thing I stress with my patients is that their diet should be very attractive to them because they want to make sure that they get good caloric intake
Yeah.
and nutritional balance. And so the most important is not to limit their diet to the point where they become malnourished, but
Hmm.
rather just eliminate specifics, but go ahead and eat everything else and enjoy it.
Hmm.
Because obviously eating food is a very enjoyable thing for all of us
Yeah.
and important nutritionally.
Yeah. Now it's interesting. Ayurveda has this concept called Agni, which refers to perhaps the strength of a person's digestion on a particular day, and this is quite common for us in our practice. That if that one day broccoli works, next day broccoli doesn't work, or vice versa, and causes great confusion to our clients. And this concept of Agni is how we tend to look at that in Ayurveda, which is that assessing a person's strength on a particular day, both for digestion and their general bodily strength, and asking clients, well, on these days when you're feeling a little weak or extra stressed out, or a little things are a little shaky or emotional, that may not be a broccoli day, and other days broccoli may digest just fine.
Yes.
And so it is an the digestive tract is an ever-changing environment where and I'm saying this for our listeners, an ever-changing environment where things can seem somewhat unpredictable at times because, well, frankly, the digestive organs have to deal with all different kinds of food and different body conditions and still perform well. So it sometimes can be hit or miss like that.
That's right.
Yeah. And this point that you made about not limiting their diet to the point where they are malnourished, a lot of the folks that are listening on today's call, because they came to Ayurveda and they're looking for dietary solutions, they tend to be folks that over-restrict in general.
Right.
And we're constantly talking about this to our clients to not overdo it. Okay, it's fine for a few days to eat a very simple diet with only very few ingredients to identify a problematic food, but not to make that last months or even years, which we get clients doing that and causing great weakness in their body.
I think that's a very important point because I have seen patients who come to me and who have been restricting their diet for a long time and are clearly malnourished and have a miserable life. And so it's very important not to restrict your diet
Yeah.
on a consistent long-term basis.
Yeah. So, what about probiotic bacteria in the therapy of IBD?
Yes, the probiotic issue and the whole area of intestinal microbial type of environment, or what we call microbiome, is very much hot topic right now.
Mm-hmm.
And we know that the intestine contains incredible high concentration of bacteria, number one, And number two, we know from DNA studies of bacterial composition of the intestine that we actually know very little about these bacteria. And on top of it, we also know that not only does the intestine have high concentration of bacteria, it also has a high concentration of viruses and fungi. And we know very, very little about any of these. In fact, out of the probably thousands of organisms, different organisms in our intestine, we probably know less than 10% of what they are. So 90% are totally unknown. There is this attempt by industry to take what they think are helpful bacteria and give it to people as probiotics. The evidence for their efficacy in inflammatory bowel disease doesn't exist. There have been several trials trying to prove that they are helpful, but in fact, none of them have so far. And so patients do ask me about it. That's kind of almost second tier question after diet. Should I take probiotics? And if you notice, the health insurance companies don't cover probiotics. And the reason again is that there's no evidence to their efficacy. So I tell my patients, you certainly are welcome to take them if you want to. They're expensive and there are no proven benefits. But I find that patients sometimes take them. There is this tendency of patients to try to take what sounds to them as a natural type of approach to healing disease. And taking probacteria sounds natural to people. And so I don't tell them don't take it. I just tell my patients there is no evidence that they're effective. And I'm not going to prescribe it for you because, first of all, you can't even buy it on prescription. It's all over the counter.
Yeah, now it's interesting in Ayurveda because, of course, the people that are coming to us are looking for natural solutions, and many of the solutions that we recommend are natural solutions as well. But the key thing that we always say in Ayurveda is get to know your body before you kind of just willy-nilly choose random probiotic or a random food solution that's been marketed to them, because people do get a lot of solutions marketed to them.
Sure.
So we in general encourage our clients to learn more about their particular system. And there's been this. I've heard some recent ideas on gut biome types, and I wonder if there's some studies that have been done on that with IBD, and is there. I mean, you mentioned that there haven't been any positive studies with probiotics, yes. But this idea of gut biome type seems also quite interesting. And finally, people can find out a lot about their own gut biome. I've heard there are some organizations that you can use to test your biome for a relatively low fee. If people are curious, more curious about what yes. bacteria are living in their gut. I mean, I want to know what's living in my gut. That's for sure.
Right. Yeah, there are organizations, and certainly there are scientists who are well equipped to try to find what kind of bacteria reside in your intestine, and they do it primarily by trying to isolate the DNA or the RNA from the stool and try to classify it into bacterial species. The problem, again, is what I said earlier, and this is that probably less than 10% of what's in our gut is even recognizable by any scientific method. And so 90% is totally unknown. And certainly none of the methodologies that people use routinely even touches the idea of viruses or fungi. And so I would just say it'd be nice to know, it'd be wonderful to know, but there's no scientific way to find out.
Yeah. Nevertheless, a frontier, right? The final frontier sometimes seems like it's another planet somewhere else, and other times it seems like it's right at home inside our bodies.
Right. There's also, I don't know if you want to touch on it, is the fecal transplant issue. Yes. This is another area that people have thought, well, if it could be a bacteria in my gut that's causing the inflammation, how about purging myself clean of bacteria or purging as much as possible and then getting a fecal transplant from a normal, healthy individual or individuals. And it's a technology that actually been developed for specific infections of the gut. But when it's been tried on patients with inflammatory bowel disease, so far it's shown no evidence of benefit. So again, it's not a technique that's approved by anyone or proven to be helpful by any scientific study that we've tried.
Yeah, well, that could be sure frustrating for folks when they're trying
Yes,
to, find these different solutions and
sure,
coming up with against some walls.
absolutely.
What about vitamins that patients with IBD should take?
Yes, that's a very important issue, especially for Crohn's disease, because Crohn's disease can affect, I mentioned earlier, the end portion of the small intestine. And the end portion of the small intestine is very specialized in absorbing vitamin B12 and also in absorbing bile acids. B12 we know is very important to prevent pernicious anemia and neurological problems. So I ask all my patients to take a high dose of B12 every day by mouth to overcome the area of malabsorption. The other area that seems to be important is the fat-soluble vitamins, and especially vitamin D. Vitamin D is very important for bone structure and also for proper immune response. And again, because of the bile acid malabsorption, patients can be deficient in vitamin D. And also, our vitamin D intake is not the main source. The main source is really synthesis of vitamin D by our skin. But most of us stay out of the sun or use sunscreens, which we should. So we don't get vitamin D production in our skin. And because of it, I always tell patients to go ahead and take vitamin D daily. So I emphasize vitamin B12, vitamin D, and folic acid. Folic acid is sometimes confused with B12 malabsorption, and it's just easier to take the two of them together as well as vitamin D.
Okay. Now, what about replacing bile acids? Is that necessary?
No, it's not possible because bile acids, if we take them orally, will cause diarrhea.
Okay. Okay.
So that doesn't work.
Yeah. Now, I've heard, I've seen some studies that have said that smoking helps people with ulcerative colitis, but aggravates people with Crohn's. Is there any explanation for that?
No, there is not. The difference in smokers versus non-smokers seems there's some evidence that patients who stop smoking have slightly higher incidence of developing Crohn's disease. And so the idea was that if you have ulcerative colitis, you should stop smoking, but certainly if you have Crohn's, don't stop. But certainly none of us encourage anyone to smoke.
Of course.
And in fact, the incidence of people smoking is decreasing very markedly, especially here in California, which is nice. I mean, I hardly see anyone who smokes anymore.
Yeah.
But it's part of the history that we take.
Yeah. And what about the role of surgery in IBD?
Right. As I mentioned to begin with, ulcerative colitis is a disease involving the large intestine only. And the large intestine, therefore, can be taken out surgically if necessary. And yet we can still absorb nutrients in our small intestine that's remaining. And so if we really fail and patients don't respond to immunosuppressive medications and to biologics, we obviously then have to resort to surgery in patients with ulcerative colitis. We do have several indications for surgery especially in ulcerative colitis. And these are diseases not responding, or sometimes there is a perforation of the bowel, and sometimes the inflammation is so severe that we cannot do anything medically. And our surgeons have very, very good approach to that. They remove the large intestine and make a new pouch out of the remaining small intestine and connect it to the rectum so that patients don't have to wear a bag externally as they used to have. Crohn's disease is a little different because we know that it can involve the small intestine, and removal of the small intestine can cause malabsorption of nutrients. And so we're very, very much reluctant to operate on patients with Crohn's disease unless they perforate or obstruct the bowel. And so we have surgeons who are attached to our IBD unit at UCLA, and they're very good, they're very experienced in this kind of problems, and we work together and make a joint decision as to whether surgery is effective or necessary or helpful, and if so, what kind of surgery. The incidence of surgery in IBD, however, is very, very small compared to the total population.
Yeah. Okay. What about resources that people can use to find more information about IBD on their own?
Very important. First of all, obviously, there's the internet, and patients do surf the internet. And all my patients, I encourage them to see what is available information-wise. Various large organizations, such as the National Institute of Health, have a website that tells people about IBD. All the large clinics have information. Most of the universities do. So that's one thing. There are also patient lay groups that meet with colitis. So there are a lot of lay groups in every large city of colitis patients that get together, have lectures and exchange information. There's also an organization called the Crohn's Colitis Foundation of America, which is short is CCFA, and they have a lot of lectures and patient education information, and those are all available, and obviously there are books. The problem with the internet and the books that are available is some of it is correct and some of it is incorrect, and some of it may be on a fringe of what's known, and so it's important for patients to learn all of this, but it's important for them to be careful and discuss it with experts before they jump to some conclusion.
Yeah, it sounds like this could be a serious condition for many people, and so if they're suspecting that they have it, they should not let things progress too much and hurt themselves.
Yes, absolutely, and it's important for patients to seek care at centers where there's a lot of experience with inflammatory bowel disease, because people who are not experienced with the disease can make their own decisions.
And it sounds like can you say where you are again? It sounds like your group.
I'm at the Inflammatory Bowel Disease Center at the University of California in Los Angeles, or UCLA. And we have a center. There are other places all throughout the country and the world with IBD centers. And one can find out about where they are simply by putting IBD center into the search like Google.
Okay. Great. Well, this has been fascinating. Dr. Hollander, I really appreciate the information that you have shared with me and with our listeners today. Very useful, very helpful.
You're very welcome. I'm glad to do that because obviously people need to know more about it.
Yes, they do.